Hello, amateur psychologists. My name is Roberts-Brysh, and I am the psychology teacher for APS Online High School. And today we are going to talk about anxiety disorders and obsessive compulsive disorder. So, our overall essential question is that we're trying to decide, look over here, what is considered abnormal behavior, as well as how it's manifested, how it comes out. And so we're going to break up that question into specific disorders because we have a couple of like groups I think that will help us better answer the question. So this week we're going to study anxiety disorders and obsessive compulsive disorder. Alrighty. So if you look in the DSM, there's a definition for both fear and anxiety, and I think it's important that we kind of talk about the difference between the two first. So one important definition is about fear, and from the DSM, fear is the emotional response to a real or perceived threat. What you feel inside to a real, or it can be a perceived threat, something that you think is a threat. And that's different from anxiety. Anxiety here is the anticipation of future threat. So it's happening in the future, whereas fear is happening in the present. Fear is a present kind of emotion that we're all familiar with. That it hits you right in the gut, makes the hair stand up on the back of your neck. Everybody has had a time in their life when they're fearful, I bet. And so an anxiety disorder is defined as objects or situation which induce the fear, anxiety, or avoidance. So obviously if I'm really fearful of something, I'm going to avoid it altogether. Say I'm an arachnophobic. I fear spiders. That's arachnophobia. I'm going to do my best to avoid spiders altogether, right? Or if I have social anxiety, I'm going to do my best to avoid parties, and I'm going to do my best to avoid public speaking. I'm going to do my best to avoid social events where, the anxiety is going to come out. It also has to have persistent fear and anxiety for 6 months or more. So it's got to be sort of an ongoing thing. So a new word you might learn today is persistent. I don't know if you know persistence yet. But persistent means ongoing, right? So for 6 months or more, the subject has had this fear and anxiety about a situation or about an object. And the person overestimates the danger in the objects or the situations that they're avoiding. So there's a definite overreaction to the situation. That's what makes it a disorder and not something that we all have. Because you should be fearful of black widows, in a reasonable way. You shouldn't never go into a basement because there might be a black widow in there. That's an overestimation of the danger. So there are some common anxiety disorders. There's general anxiety disorder. Sometimes it's abbreviated GAD, GAD. There are specific phobias, so we'll talk a little bit about those. And then there is another disorder called social anxiety disorder, which we'll get into a little bit too. But all three of these are fairly common in terms of anxiety disorders. Let's start with generalized anxiety disorder, and here is the diagnostic criteria. So if I was a psychologist and I was meeting with somebody, and this person is talking about their anxiety, the person would have to meet these criteria here in order for it to count as generalized anxiety disorder, in order for me to make that diagnosis. So, every mental health practitioner is going to be a little different though, because a lot of the criteria here are up for interpretation. It's what I declare as clinically significant as a clinician that is going to say whether or not I would give this diagnosis out, right? So I may have a different opinion of that than you might have. So the first criteria is that you have to have excessive anxiety or worry occurring for more days than not for at least 6 months. So excessive is one of those subjective words. What's excessive to you may not be excessive to me, but um, the idea here is the anxiety or worry is out of proportion to the actual danger, right? I might have a fear of flying, let's say, and I don't know if you know this or not, but air travel is fairly safe. It's much more safe than car travel, right? But I'm not scared of cars. I'm scared of planes. And so this anxiety, this worry, makes me avoid going on vacations where I have to fly, and makes me nervous to step into an airport. And I don't even like looking up in the sky and seeing a plane. That would be excessive anxiety or worry. Another diagnostic criteria is that it's difficult to control the anxiety, the worry, the feelings that you have from that particular situation or object. So it's difficult to control. That's important. And then you must have three of the following, three or more of the following: restlessness, becoming easily fatigued, becoming easily tired after having dealt with whatever's causing the anxiety, difficulty concentrating, or your mind going totally blank. Irritability is one of them. Muscle tension, being really tense, and that's pretty common for people who don't like to fly. They get really tense on takeoff and landings. They don't like turbulence. So muscle tension is pretty common. And then sleep disturbance. Not being able to sleep very well is also a symptom. And then these two bullet points you'll see repeated all the time when we're talking about diagnoses. And the first bullet point talks about whether whatever the disorder is moving from just being something that somebody can deal with to impacting their entire life. So that's what clinically significant impairment in functioning means. It's kind of a bunch of big words, but really what it's trying to get at is that it's really getting in the way of someone's ability to perform in school, or ability to go out and talk to people, or ability to get a job and work. So if there is clinically significant impairment in someone's ability to do school, or someone's ability to talk to and interact with other people, or someone's ability to work and keep a job, then it's clinically significant. Then it rises to the level where you could diagnose it as a disorder. If it's not causing significant impairment, then the clinician won't be diagnosing it. You might have some of the symptoms, but it's not excessive enough. Or it might be difficult to control the worry, but if you really work hard at it, you can do it. It's not affecting your schoolwork. It's not affecting how you talk to other people. It's not affecting your job. Okay, so that's an important thing. You'll see this all the time. And then the last bullet point here is, it's really important to rule out whether or not the anxiety is caused by something other than just thinking about the anxiety, just thinking about the object or the situation. So, it can't be due to a substance, and it can't be due to a medical condition. So it can't be due to an underlying medical problem that someone has that's forcing them to feel anxious. So that is the group of criteria that you need in order to be diagnosed with general anxiety. So let's take a look at an example. So these are the criteria that we just had. You're writing down your notes. These are the criteria that we just had to diagnose Peter. Right? You're playing the part of Claire. Right? She's the mental health counselor. And then Peter comes in as a client. And Peter's a high school student. Walks into the office. And Claire's working at the local mental health facility. Peter sits down and talks to Claire, and he's constantly worrying about violence at his school all the time. He reports he's so nervous that someone will bring a gun to school and, commit a horrible school shooting. And he feels like his heart is racing all the time. He often feels sick to his stomach. He also reports he can't concentrate at school. He can't fall asleep at night. He's worried about his classes and his schoolwork. He's worried about all of this affecting his ability to get into college. So the question is, would you diagnose this person as having general anxiety disorder? So the question you have to ask yourself is, does Peter meet all of these criteria here? Is he finding it difficult to control the worry? Let's assume it's been 7 months that he's been feeling this way. All school year he's been feeling this way. Is he restless? Is he having difficulty concentrating? Is he having sleep disturbances? Is it causing clinically significant impairment in functioning? And are all those symptoms because the person is on a substance, or because Peter has a medical condition? That's what you need to think about in terms of your diagnosis here. And most people who read the story, go through the criteria there, say that he would be a good candidate for general anxiety disorder. So. Another type of anxiety disorder that's kind of related to general anxiety are phobias. And I'm sure out there, who's watching this, I'm sure you have had some experience with knowing what phobias are. We'll go through kind of a list here in a little bit too, but here are the diagnostic criteria for phobias. So number one, there has to be a marked fear or anxiety about a specific object or situation. So some typical ones are like heights. I already talked about flying a little bit. There are lots of animals people are anxious about: spiders, snakes, dogs sometimes. The object or situation has to always provoke immediate fear or anxiety. So as soon as the person is in the situation, as soon as the person sees the spider or snake or whatever, as soon as the person has that experience, it's immediate fear. It's not later, it's not 5 minutes later, it's not 20 minutes later, it's not tomorrow. It's immediate, like, wow, they have an immediate reaction to it. And then the object or the situation is avoided. And if the person can't avoid it, if the person can't get away from the spider, if the person can't get off the plane, then the situation is endured with intense fear and anxiety. The person's, gutting it out the entire time. But they are terrified. The person's terrified the entire time. Like mind-erasing terror is what we're talking. Total freak out. The fear or anxiety is out of proportion to the actual danger. This is an important one here. Let's highlight this guy. That's important. That the fear or anxiety is out of proportion to the actual danger. If you have a fear of dogs and you come over to meet my dog, and my dog is nice and, he'll lick you and he'll sit and he won't come over to you, he won't jump on your lap, he won't do anything that's threatening, but you're still absolutely terrified of dogs. Anything furry with 4 legs and a tongue that will lick you, and you're worried that every dog you see is going to rip your face off because maybe you were attacked when you were a child by a dog, right? One dog is not all dogs. Most dogs are not going to come up to you and tear your face off. Most dogs are going to come over to you and want to be petted, right? And then the fear anxiety has to be persistent. Remember that word persistent we talked about. So 6 months or more. A lot of us have fear anxiety about, maybe presenting in front of a class, going to one of our webinars and having to show off a project. Or, you just got bit by a dog, you might be scared of that particular dog for a while, but this has got to be something over months and months. And it has to have, obviously, the clinically significant impairment and not due to substance use or medical conditions. Right? So remember those. We're going to see those a lot, remember. And so if the person meets all these criteria, then he or she could be diagnosed with a phobia. I'm sure you can think of a lot of different phobias. Here are some common ones. There's agoraphobia, which is fear of being outside in large spaces. Hematophobia, fear of blood. I don't know if you've met anybody that faints at the sight of blood, but there are those that do. There's pteromerahanophobia, which is fear of flying. It's a big one. There's arachnophobia, the fear of spiders. Bacteriophobia, fear of germs. Archophobia is the fear of heights. And there's glossophobia. Many of you have fear of public speaking. So those are some common ones. I'm sure you can think of other ones like claustrophobia, fear of enclosed spaces and that sort of thing. But there are a number of different kinds of phobias out there that I'm sure we can all think of. And the third and final common anxiety disorder that we're going to talk about is social anxiety disorder. Here's the DSM number that has right there. And if we're diagnosing somebody with social anxiety disorder, we're looking for these things here. You're looking for a marked fear or anxiety about one or more social situations. Going to parties, talking to groups of people, public speaking, those sorts of things. This is a really important one for social anxiety. The person believes that the symptoms themselves, like the stammering, the not knowing what to say, the becoming totally blank and not knowing what to do. The person believes that those symptoms will lead to humiliation and rejection by everybody at the party, or everybody, the audience that you're publicly speaking in front of, that sort of thing. So that's a really important one to keep in mind. When I was going through my practicum, I had a client who was diagnosed with social anxiety disorder, and he described it to me as an intense fear, really, of any sort of social situation. He would go to a party, for instance, right, and you'd be talking to people, and the entire time he's talking to people, he's thinking, what are they thinking about me? Do they like me? Do I have something in my teeth? Are they going to reject me? Or do they think I'm stupid? Do they think that I'm ugly? Are they looking at my shoes? Are my shoes out of date? And it would just be this constant stream of sort of like negative self-talk all the time. And it would just lead him to like freeze up and be paralyzed. He passed out a couple of times because he's so afraid and so anxious that he would freeze, and the freezing would just lead him to, he would wake up on the floor and have totally passed out. And then, that leads to more embarrassment, right? And more humiliation, and people are wondering, like, why is this guy so weird, And then that, people say that sort of thing, and then that leads him to believe that he is weird and different, and so that is just, like a snowball effect is what he called it. So social situations provoke fear and anxiety, like my example, right? And the social situations usually are avoided, right? Or they're endured with intense fear, and the example that I gave, the guy passed out even, right? That's how afraid he was. And the fear or anxiety is out of proportion to the actual danger. Obviously, there's very little physical danger in a group situation, but there's a lot of emotional danger in terms of humiliation and embarrassment and that sort of thing. But there's no physical danger, right? And then there's fear, anxiety, can't be due to the substance, right, or a medical condition. And if the person has those symptoms, then the person might be diagnosed with social anxiety disorder. So the first three were anxiety disorders, and this next one, obsessive compulsive disorder, is sort of its own kind of category. In the DSM-5, is its own chapter in there. Like the anxiety disorders have their one chapter, and then obsessive compulsive disorder is its own chapter. And so before we start talking about obsessive compulsive disorder, we probably need to talk about obsessions and compulsions. So An obsession is a persistent, unwanted thought that causes someone anxiety. And the second part of an obsession, because you need two parts, the second part of the obsession is that there's an attempt by the person to ignore or suppress that thought by substituting a thought or by doing something, by an action. The action is going to be the compulsion. And then a compulsion then is a repetitive behavior that the subject feels that she or he must perform to take away the anxiety, take away the feelings of fear and anxiousness that the person has. So the compulsion is the action, the obsession is the thought. Let me give an example, maybe this will help. So let's say a person is really frightened about someone coming in and breaking into his or her home. So this person gets up all the time, checks the front door 12, 13 times when this person gets home every day. And while he or she is checking the door, the person's got, let's say, 3 locks on the door, 4 locks on the door, something like that, because they're scared of someone coming in. And it's unlocking, locking, unlocking, locking, unlocking, locking, unlocking, locking. And then the person goes and every day this person will do unlocking, locking, unlocking, locking, unlocking, locking, unlocking, locking 12 times before he or she can feel like calm and ready to be able to not feel like someone's going to burst through the front door. And the ritualistic behavior alleviates the anxiety that someone's going to break in, right? So you do the ritual over and over again, the ritual of unlocking, locking, a dozen times. And then when no one breaks into the house, the person believes, hey, you know what made somebody not break into my house? Unlocking, locking, unlocking, locking, unlocking, locking. And to the person with OCD, if she or he did not continue to do the unlocking, locking, unlocking, locking, then something horrible is going to happen. So it's like a cycle, really, a lot like the social anxiety was, we were just talking about. You feel the anxiety, you perform the behavior, it alleviates the anxiety, nothing bad happens, so you have to perform the behavior again next time you feel anxious. That's kind of how it goes. And then it's just constantly perpetuating. So it goes all the time. And so some common therapeutic techniques, if you were a psychologist and you were seeing somebody who had OCD or who had social anxiety disorder, or who had a phobia, or had generalized anxiety disorder, one of the important therapeutic techniques is to get the person to deal with the physical symptoms of fear and emotional symptoms of fear. And so you would use relaxation techniques. So the person knows, okay, I'm stepping on a plane now. I know I'm going to be anxious, so I'm going to go through my relaxation techniques so I don't hyperventilate, so I don't let the anxiety take over. It's one of the first things that a lot of people do in therapy is relaxation techniques, because you want to make the person feel in control of, as much as they can, of the anxiety. And then there's a process of systematic desensitization, which is two fancy words of saying that you do baby steps until you confront the fear. So it's systematic in that you're going to take little, small, incremental steps. And it's desensitizing because it takes the fear that was really scary at the beginning, and you're going to be exposing yourself to it. Sometimes it's called exposure therapy. And you're going to be exposing yourself to it until eventually you realize that just flying on a plane is not going to lead to a horrible fiery crash every time. So if we take our plane example, first our therapy is going to be to close your eyes and think of going to an airport or something like that, right? And so you close your eye. The subject closes his or her eyes, and you would be talking about what it's like to go to an airport and the feelings inside and all those sorts of things. And then you would start to watch movies about planes. Then you would start to go to the airport. Then you would start to get on a plane but not fly anywhere. Then you would start to get on a plane and fly a short distance. Then you would start to get on a plane and fly a long distance. And over time, the person will get more comfortable and more comfortable and more comfortable with what is exactly happening. And so you start with small doses, right, in a controlled setting inside the therapy room. And then eventually what you'll do is lead the person to real life experiences with that particular fear, whatever it is. And most psychologists or mental health professionals are going to use cognitive behavioral approaches, things like thought stopping. So when you're feeling anxious and your thoughts are racing about how anxious you're feeling and about how what's going to happen next and all that sort of thing, you're gonna have a situation where you're just going to stop the thought. You're going to think in your mind of a big giant stop sign. It's going to stop that thought. Every time you have that thought, you're going to think of that thought stopping. That's what thought stopping is about. And then you're going to challenge biases. What you're really trying to do is you're trying to get the client to imagine or to believe that not every encounter with this fearful thing is going to end up in a horrible situation. So if you have a fear of dogs, you're going to maybe say something like, well, you had a dog when you were a kid that didn't bite you, didn't attack you. What was that experience like? And then you're going to replace some of the negative self-talk with positive self-talk. So remember my example of the client who would get in a social situation and he would just think of all the worst things that could happen in that particular social situation. The worst thing that somebody could be thinking about him while he was talking to them, that sort of thing. You would work with the client to try and replace the negative self-talk with some positive self-talk. And then you would try and get the client to use the positive self-talk before the situation or object appeared. So you sort of positive self-talk your way to work up toward the party, so that you're not so fearful of what other people are going to think and say, and then you're not all inside your head. You're able to kind of enjoy the party and mingle with people and talk about things and that sort of stuff. And the ideal, I guess, would be to increase their confidence. So you're going to help the client find ways to increase his or her confidence. And part of that is with the systematic desensitization. The more hurdles they overcome, the more little baby steps they take toward confronting the fear and the final kind of desensitization step, the more confident the person's going to be. So that's very important. All right. And there's the reference. We use the 5th edition for the DSM. The brand new one. Well, not brand new one, 2013 one. And hopefully today you learned a little bit about what abnormal behavior, in quotes, consists of in terms of anxiety and obsessive compulsive disorder, and what it looks like in somebody who has that disorder. So that was the goal of this little video. So hopefully you all learned that, and you will be able to do well on the quizzes and tests in the future. When you have questions, of course, make sure you come and contact me so that I can answer them, so that I can walk you through if you need a different kind of explanation, or show all kinds of examples of these. So just let me know, and I will be happy to help you out. All right, everybody, thanks, and have a good week.